Welcome back to the Autistic Tidbits and Tangents podcast. I'm one of your hosts, Cara Diamond. I'm an autistic teacher, university lecturer, researcher, and author from the Greater Toronto Area uh, in Canada.
You're always not people are not going to know what the Greater Toronto Area means. That actually can
Well,
mean all of Ontario.
Literal, and I can't be that specific. I'm outside of Toronto by, I don't know, 45 minutes.
And my address is, um, hi, I'm Bruce Petherick. I'm an autistic musician and advocate, and I live in Vancouver, which everyone knows where that is, British Columbia.
And we have a guest we're really excited to talk with today, Dr. Paula Holmes-Rodman. Yay, thanks for being here. I'm going to tell you a little bit about Paula before we get started. She is a multidisciplinary scholar, writer, and facilitator whose work bridges interpretive anthropology, narrative-based medicine, and patient advocacy. She has a PhD in religious studies from McMaster University and postdoctoral training in anthropology at SUNY Buffalo. She spent over 2 decades exploring postcolonial Indigenous identities, ethnotheology, and narrative repatriation, and grounds her scholarship in practices of reclamation and narrative justice. Her recent advanced certificate in narrative-based medicine from the University of Toronto reflects an applied turn toward clinical and community settings. Working closely with Autism Canada, she developed the Self-Advocacy Guide for Cancer Patients on the Autism Spectrum, a resource recognized with the King Charles III Coronation Medal. She continues to collaborate with organizations such as Ovarian Cancer Canada, Hospice Calgary, and Wellspring to support equitable story-based care through workshops, guides, and webinar series. She's also presented nationally on psychosocial oncology, health humanities, and patient navigation, and contributed to the development of advocacy programs. Her work blends scholarly inquiry with collaborative engagement, offering frameworks for listening, legacy making, and resilience across medical and cultural borders. In both institutional and grassroots spaces, her approach emphasizes relationality, co-authorship, and the transformative possibilities of story.
Welcome to the Autistic Tidbits and Tangents podcast.
Candid conversations between autistic off-hour professionals.
With lots of tangents in different accents.
Each person's viewpoints on this podcast reflect their backgrounds and temporal perspectives at the time of recording, and do not necessarily reflect the views of everyone else. We believe that personal growth comes from listening and reacting to multiple perspectives, and that conversations can be catalysts for change, connection, and greater understanding. Thanks for being part of our community. Content warnings for this episode include mentions of medical ableism, various barriers to care and healthcare, abusive relationships, assisted dying, colonialism, and there's some gentle swearing.
Oh my goodness, we are so excited to have you.
That's a lot to live up to.
I feel like that too.
Let me just say.
Bios are the worst, and it's always hard to sit and listen to your own, So
Yeah. Like that sounds like a great person. I should be her.
Exactly. It's aspirational.
It's an aspirational bio, basically. But thank you for having me.
Well, Bruce had been telling me all about your self-advocacy guide, and that's something I think we really want to delve into. It's going to be what we call our thing of the day. We always like to feature at least one resource, if not more. And we're going to ask you all sorts of questions.
Great. Yeah. And I should say, so I'm not autistic. I don't tend to use the word neurotypical. I sometimes do because that actually, again, assumes there's a norm from which others diverge, which I'm not a fan of that. So when I'm in these spaces, I just say I'm not autistic. But my sister, who we're going to be talking a lot about, her name is Lindsey. She was. So I come to this knowledge from an outside perspective, from that of an advocate, an ally, a caregiver, that sort of thing. So just for your audience, I think that's important to say as well.
Thank you.
And for openness, I should say that Paula and I worked together on the guide when I was at Autism Canada, and that she and I continue to work together on some other things.
Amazing. I wonder, just to get us started, I'd love to hear a little bit about Lindsey.
Yeah, so Lindsay was my big sister, and she died last year from ovarian cancer. So she was 4.5 years older than me, and so ovarian. She was a late diagnosed autistic woman. She was diagnosed with autism at 49. So that was a diagnosis that she sought for herself.
Wow.
So she grew up. She was born in the mid 60s in St. Louis, Missouri, to a very young mother, now deceased, who honestly didn't know what the heck was, quote, wrong with her daughter. She knew, she just kept trying to get support. And we didn't have the language, we didn't have the
Yeah.
support. She had nothing in school. Um, all the things that I would have hoped that, somebody born now would have going forward.
Mhm.
So at 49, she sort of knew she was different, wanted to seek out a diagnosis that was expensive to do independently, to seek
Yeah.
an independent diagnosis, as I'm sure you all know. So she ultimately did get diagnosed in Calgary at 49. And I think what she told me was that was not so much like, oh gosh, this is news to me, but it's sort of like, well, it doesn't change anything. Now I have some language to describe who I am. Lindsay felt very sort of that, what I call the siren call of normal. And I think that's because that's how she was raised. Because for her, normal was the goal, right?
Mm.
Normal was the goal. There's lots of air quotes going on. Normal was the goal. She felt abnormal
Oh.
and wanted to be normal, whatever that was. So she really sought that rather than being supported as someone who was just different, just a different person. So as her story goes on, actually, her understanding of herself as an autistic person through her illness really, and this is where I will get watery eyed,
Me too.
because her understanding of herself as an autistic person really happened at that same time as her illness and end of life experience happened, for which I feel incredible gratitude and incredible grief. It's
Actually,
almost like compounded grief. Yeah.
I talked to Lindsay maybe 4 times,
Yeah.
maybe 4 or 5 times after the diagnosis, and I saw a late diagnosed autistic person who was really quite comfortable with their autism.
Oh,
Not
yeah.
perfect. And it was just like, it's kind of interesting that you said that she wanted to be normal. And it's like
Mhm.
that's not the person I knew, which is wonderful. It's delightful.
Well,
Yeah.
I think for so many late diagnosed people too, once you realize you're part of a community and you start to connect to other people, and then you realize, like, it just opens up so many other possibilities. And that
Yeah.
idea of so-called normal goes away. Like, there is no normal. You
Yeah.
can be who you want to be. Now, I'm curious about, for Lindsay, um, so was she did her late diagnosis come during the cancer process? Like, had she already been ill? Like, how did this, what was the interplay between late diagnosis of autism and developing the self-advocacy guide?
Sure. So not immediate. So she was diagnosed at 49 with autism,
Okay.
and then at 53 she was diagnosed with ovarian cancer.
Okay. So 4 years
Um,
later.
so 4 years later. So in some ways, there's what I call in the narrative medicine world a biographical disruption, right?
Hmm.
So there's still you're going along, you think you are who you are, and then suddenly that almost like a biographical confirmation, the
Hmm.
autism diagnosis was, and then becoming ill was that biographical disruption. It's that
Hmm.
holy shit, now what moment. And so ovarian cancer for most people, of course, anyone born with ovaries is at risk for ovarian cancer. It is normally diagnosed later, like most of them, it's diagnosed stage 3, stage 4. It happens in the abdomen. For female people who are like, I don't know what's going on down there. We've got bladder symptoms, bowel symptoms, weird period symptoms. That's just a Tuesday for
Right.
most females. It really is,
Yeah.
right? So she was diagnosed at stage 4 at 53. So the fact that she had 4.5 years of actually not bad health during and actually really good response um, was kind of miraculous, because the 5 year survival rate sucks
Yeah.
for cancer for everybody.
Yeah.
But autistic people, there's not a lot of research on autism and cancer, certainly very little out of Canada. We do know that autistic people have the same opportunity for cancer as non-autistic people do. And we also know that they have a worse outcome. We think at about a 2-to-1 ratio.
Interesting.
Why? Right? They tend to have the same barriers to early access to care. So we know for any cancer, the earlier you get, screened, diagnosed, the more options you have, the better outcome. So there's medical mistrust, there's trauma and abuse in the healthcare system, there's situational mutism in the healthcare system, there's sensory overload, there's communication.
Mm-hmm.
So all of these things that, everybody on this call and all your audience knows about makes it difficult if you're thinking there's something kind of weird going on in my body. I have a pain, I have a worry, I have concern. Let me find a doctor, go to a doctor, speak my concerns, advocate for myself, deal with the weird sounds, the noises, the feelings, like all of that, and then proceed entirely on my own through a cancer care system.
Yeah.
It's just bleh. So that's the technical term, bleh. It doesn't work. So we know that's really the technical, the high research term, bleh. Doesn't work. So basically, how the self-advocacy guide came about. So when Lindsey, I'm kind of bouncing around a bit. When Lindsey was diagnosed, she lived in Alberta and I live in BC. So I was flying back and forth, playing self-advocate for 4.5 years. And when she was diagnosed at the Tom Baker Cancer Center, I remember taking the nurse aside and I said, my sister is autistic. She's going to need a little help. That's it. That's all I said. I didn't know what I needed. I'm like, just help me. I know she's different. I know this is going to be extra super duper hard for her, but I didn't have the words to ask.
And would they know? And they might not know either. It comes down to the knowledge of the individual practitioner.
They knew nothing. So the guide ended up being the thing I wished that nurse had said, here, here you go. So since then we've developed a patient-facing guide, and I'm also working on developing, provider tools as well. So I've been working with the Canadian Association of Nurses and Oncology, doing presentations for them, BC Hereditary Cancer, because if we don't educate the healthcare providers, we're only doing half the job.
Absolutely.
Actually, we're only doing a third of the job because we also need to change the physical environments as well.
Yes.
So that's, so I think we need to do patient, provider, and the physical place as well.
Bruce, so you've seen the guide. What are your thoughts? How does the guide change the conversation?
Quite honestly, when I first read the first draft that I saw, it really reminded Cara, my dear friend, of what you and I have been doing in education. You obviously much more. And I found so much commonality. And in fact, now Paula and I are looking at doing some further work and more discussions, and me talking to even people yesterday. I'm seeing this lack across all disciplines that we need to be giving autistic people, and let's spread this to neurodivergent people, guides to what is going on. What's going on in education? What's going on in healthcare? And it all comes about self-awareness.
Yes.
Knowing what you need to know. Paul and I talked a little bit the other day, 2 days ago, about my problem with alexithymia and interception. Okay. So I don't know, I don't have hunger cues.
Interesting.
So I need to schedule, I schedule meals.
Yeah.
Every morning I have the same breakfast. Lunchtime, I usually have alarms, or if I'm working in a situation around 12 o'clock, I kind of do a body check-in. Now, what I've done is, because I'm a musician, and also because in my past I was a professional sports person, a professional soccer player, I am hyper aware of what my body should do.
Yeah.
And that is practice. That is me playing the piano for 6 hours a day and going, that's what this should feel like. That's what this should feel like. That what should this feel like. So if I've got something physical wrong with me, I'm pretty aware from experience, from learning myself, that I've got a pain in my arm and I should be able to do, hang on, this, but I'm doing this. I can feel resistance right here in this muscle and this muscle. I'm very aware. Something internal, I have no idea. I have said before, I have a heart condition. My heart stops once a minute. Every single cardiologist has told me that I should feel this. Every single cardiologist tells me, don't you feel your heart racing and a stop? And it's like, no. So I have taught myself to be super aware about my external body. I haven't done that work enough, or I'm not even sure since of my age I can do that, of my internal situation. So this is the self-awareness that we need to encourage all neurodivergent people to point out that there is a normalcy, a conception that people are supposed to understand how this feels. People are supposed to feel their heart racing.
And
people
be able to explain it.
And that we can sometimes or often struggle with that, and that's okay. We need to then work on how we can be self-aware, how we can think of other ways of expressing. And then the flip side is having teachers, having doctors, having lawyers, having politicians, having policemen, recognizing that their concept of normal does not apply to us. And they also need to be thinking about what's another way of us expressing. That's all those thoughts came to me the minute I start reading chapter 1 of the guide. No, it was reading the guide, feeling very connected to what your writings, Cara, how I was presenting workshops at Autism Canada, and seeing this very holistic response. But the cancer guide is very, very specific to the process, which is important.
Yeah, I love that it sort of is grounded in agency of the person, first of all. So much of it is about like what do you see as quality of life, and what is important to you, and what sensory experience is important to you, and how do you respond, and then how to make the process more predictable as well, which you and I talk about all the time, Bruce. Like predictability matters, and I absolutely love this guide. Now, I'm wondering, Paula, from your perspective, first of all, like as a caregiver, you mentioned that like this would have made a difference had you had it. How do you think your experience would have been different if someone had given you this right at the beginning?
Well, I think I conceptualized the guide as a kind of parallel medical chart. So in narrative medicine, we have the idea of parallel charting, and that originally I began as basically a healthcare provider taking a regular old medical chart and writing their feelings about it. So, for example, if you have a healthcare provider taking care of somebody who's 70 and they've got prostate cancer and it's bringing up feelings about their grandfather, so then they can have a reflective writing exercise about that. But I took that idea and went, I don't like it. I'm going to make it different. So let me say, in my view, a medical chart is a spine. It's rather fleshless. It's rather lifeless. It's not corporealized. And it doesn't tell the entire story. There's backstories, pre-stories, scaffolding, extra lines, characters, all this stuff going on. So that's sort of the conceptual, I thought. So how do we get that, corral that into a document that could possibly then be helpful? So it is both a mirror for the patient and their support team to sort of fill out and say, this is how I am. This is how my body works. This is how my brain works. This is how I feel, I express decision making, consent, this sort of thing.
Yes.
The overall goal is to reduce diagnostic overshadowing. That's one of the goals. We know that's high risk.
Can you explain that, please?
Oh, yeah. Diagnostic overshadowing happens a lot for autistic and other neurodivergent people. It also happens for people who live in larger bodies, people with mental health issues. So basically, if you come to me and you say, I've got a pain in my abdomen, but I know you suffer with depression, I'm going to say, well, it's your depression.
Right.
And so for Lindsey, what this looked like, so when she had a very rare recurrence of ovarian cancer, it recurred as a brain tumor, which is very rare, like a 1% to 2% chance. Usually, it recurs in sort of liver, abdomen, lymph nodes.
Yeah.
It's the abdomen, its usual haunt, as I consider it. So when she started having, obviously brain tumory symptoms, she was getting lost. She was having these profound headaches, and she was going to the emergency room, and they said basically it's autistic burnout. She was prescribed yoga, meditation, muscle relaxants, these sorts of things. I feel part of that, and this was happening. I wasn't there, of course, for every single emergency room visit. In looking back, I wish I had. So by the time it was diagnosed, it was a 5.5 centimeter brain tumor. And so she did have a craniotomy. She did have radiation, but that was September. And so she died in April. So then we were looking at sort of end of life care, which may have happened anyways. I mean, let's face it, it would have happened anyways, autistic. But diagnostic overshadowing is basically, it's like I'm looking at you as a healthcare provider. I'm taking in pieces of information, and I'm not taking your physical symptoms as seriously as I might if you presented otherwise.
Yeah.
So I'm not getting the right diagnosis because I'm hyper focused on something else. Oh, you're autistic? That means this thing that you're bringing to my attention is your autism.
It's like detectives only honing in on one suspect and not looking at everybody else.
That's exactly it. That's exactly it. Yeah.
It's interesting when you said that the ER diagnosed her with autistic burnout. It's like,
yeah,
at least they knew what that was. And
well, that was me diagnosing.
Yeah, that's Paula.
Okay, sorry.
It might be autistic burnout. Because and then like tell the doctor that. So no, that was me being a medical Cyrano from another province. Because no, they're like, you're depressed, like have some yoga, relax. Here's some Valium.
Oh my God. Have you tried relaxing? Oh my God.
Have you tried relaxing? Yeah, exactly. And I'm like, well, I think, and then I mean, she was getting lost going to the end of the block and back, right?
Yeah.
And meanwhile, she'd lost her job and she was trying to get a new job. And so she's feeling like she's failing as a new employee.
Yes.
Which was a horrendous feeling for her. So, anyways, I think that these sorts of situations end up with autistic patients being labeled as, first of all, their behavior gets labeled as compliant. They're super compliant, particularly those female at birth. Oh, they're the best patients ever. They're what I call the well and good patients.
Yes.
They give, and Bruce and I talked about this, they give the right answer. They're quick. They're quiet. It's the yep, yep, yep response. We're in, we're out. Oh, you gave consent. You understand. You have no questions. Excellent. Bye. Next. Or you get someone who has a meltdown, a shutdown, and then they're non-compliant. They're resistant to care. They're, all of these sorts of things. So then you get these diagnoses that are, in fact, perhaps if that patient had a different communication system, different sensory supports, the healthcare provider and the patient could have a different conversation and we'd have a different outcome.
Well, and I know we're in different provinces, but I also think about like here in Ontario, the doctors will say you can only bring up one issue per visit. So then if I have multiple symptoms, what am I going to say? And I'm very literal about things. Do I only go and say I have a little bit of stomach pain, or do I say I have stomach pain and back pain and whatever all the things are that might be connected?
I've always ignored that. Like,
well,
it was the same in BC. Actually, same in Australia.
Rules, Bruce.
Yeah. Oh no! When you see, no, it's like
you're a rule follower. Yeah.
You can,
However,
you can only say one thing. It's like, no, I have two things, and that's what I'm going to tell you. And
I am making like a body map where I'm drawing a body and then like little symptoms attached to different parts of the body, and I'm going to take that in. It's going to have everything. It's going to be holistic view.
Yeah.
Well, I'm trying to get to the root of some autoimmune things, right? So,
Yeah,
yeah.
exactly. And those are really, I mean, any kind of autoimmune thing is, as we know, very hard to diagnose, period, for anyone. And some of these things, like, again, a cancer diagnosis or any kind of complex illness can be, I mean, if you go in going, my heart is doing weird things, you're going to say, okay, let me look at your heart. Then we're going to talk up to a cardiologist. But if you go and going, I don't know, like my bladder, my bowels, my periods, my bloating, my
All these
back pain,
things.
my like, who cares? Like, it's just go away, lady. So I think
Go away,
that's
lady.
difficult, pretty much, you know. So, anyway, so all of those things are sort of for every cancer patient, and then they are compounded and multiplied, I think, for autistic patients. I feel, anyway. So,
Mhm. Um, I really loved the pacing section as well of the
yeah,
guide. Like, how do you, as the patient, want information conveyed to you? Like, do you need processing time? Yes. I really love like that. You get the patient thinking about it, the caregivers thinking about it, the medical practitioners thinking about it as well. That's so, so, so important.
ideally. The problem is we're dealing with, as we just said, we were just talking about this. You've got 2 minutes. Speak fast. So you can go in there and you're like, I'm so self-aware. I need extra processing time. I'm a visual, I need written information. And then we're going to have a conversation about this. I can be this like most self-aware. This is what I need to communicate well. And someone's like, that's awesome. You have 3 minutes. Go.
And I know you and Lindsay had like a
Yeah.
system, right?
Well, I mean, I a little on the pushy side sometimes when it comes like I had mother bear energy. I was told by somebody in the hospital. I'm like, yeah, mama bear energy. I'll take it. I'll take it
Yeah,
for
yeah.
sure. So yeah, the system that we had was that I would write notes. I'm a very quick note taker in the medical world, having done it for my mom, having done it for my sister a long time. So I can quickly take notes of someone saying, and I've got my own system, which then encouraged Lindsay just to sort of be present to what the doctor was saying. And then I would type up the notes, share the notes with her and whoever else she wanted me to. And then we could talk about it. We could say, the doctor said, remember the doctor said that. The doctor was talking about that.
Mhm.
So that worked for us. Um, a lot of her cancer experience happened during COVID, the original thing. So I wasn't even able to be there. So we had to do it. And there was no cell service in the basement of some of these cancer centers. So it was a bit bonkers. They weren't set up to have any caregiver there at all for
Oh,
any
that's so
person.
difficult.
So we kind of like, I was doing Facebook Messenger, like
Yeah.
WhatsApping, I'm like, I'm going to make it work. But yeah, the problem with this is I think one of the reasons for the guide is that I realized that as a caregiver, I don't know if your audience probably can't see me. I had that feeling to just wrap my arms around her and sort of carry her through this entire thing. Like everyone is going to make sure I will write on the patient, every single patient board. She's autistic, check understanding, slow down. I would write that in green marker I would take over the unused patient
Mhm.
boards. Every day I'd have to rewrite that because someone would smudge against it and they'd
Mhm.
ignore it. So that feeling of that sort of hyper, caring is fine. But then I would have loved to have just been her sister sometimes,
Yes, of course.
rather than her advocate and her medical cyrano and like her
Yeah.
nurse and all of those things. So I think one of the ultimate goals is if we put some of these things in place, we standardize this as care.
Mhm.
Um, then you can allow those caregivers to, rather than sort of do this big covering umbrella thing, to just simply hold their person and do that emotional care
And I
rather
know,
than argue and fight and advocate for you the
yeah,
whole way through. Yeah.
which takes so much energy, and yeah, then you don't get to do the role that you really want to do,
Yeah,
which is walk
exactly.
side by side.
Exactly. Yeah.
I also really appreciate about this guide, and I'd love to hear more about your experience and Lindsay's experience. Um, the guide focuses so much on the patient's consent and the patient's patient being able to make medical choices for themselves. So yeah, tell me a little bit about that. Like why was that so important to both you and Lindsay?
Well, I feel in general it's important for every patient to be able to give consent
Certainly.
and I mean to have, and that we all have different ways of expressing consent, and we all have decision making, capacity. Um, so with Lindsay, she was in an abusive relationship for 6 years, and when her cancer came back, I didn't think this person was that awesome to begin with, but I thought, well, it's her choice. I'm doing, that sort of language in my head. And honestly, I didn't live there. And so she had someone who was with her on the daily. Um, However, when her cancer recurred, I will remember this vividly. We were getting a get your affairs in order conversation from the nurse. And he spoke up and he said, I'm the husband. I will make the decision. And he also sort of, I began to notice, was using her autism against her. She's disabled. She can't make a decision. And I got a, oh, hell no response in my body. Like, this
Yes.
is not on my watch. Because I knew my sister well enough to know she understood what was going on in her body. She has had the ability to make her own medical decisions. And that this was part of abuse and control and not
Yes.
supported decision making documents. So I put the supported decision making documents in place. This was hard because Lindsay was having a difficulty understanding that she probably was approaching end of life. So I had to kind of dance a little bit.
Yes.
But the happy, griefy, gratitudey place I ended up is that so Lindsay spent 5 months in hospice because she had an unstable home life. It was a hoarder home life. Her partner was going to have open heart surgery. He said that he would care for her and he would be the one who would be the person who would define who could come in and out of the house. And he was going to care for her at end of life. And yet Lindsay needed a walker and had lost 50% of her vision. And the house, you couldn't even put a walker in the house.
Oh my goodness.
This
He
is
knew and he'd been told. And we went over and over this, like with all the people in the hospitals, so many
Yeah.
times.
this is the third time I think I've heard this story from you, and still I'm
Yeah.
going, what? How?
Me too. And I'm like, I should have done this earlier. And then it's like, I have to give myself grace. Anyway,
Yeah.
Yeah, you definitely do.
so there was this amazing palliative care doctor who she knew through the HIV clinic that she attended, and her husband attended as well. And he facilitated an early admission to hospice.
Oh wow.
And this turned out to be the most amazing thing, actually, because Lindsay lived this incredibly, actually very healthy 5 months in
Yeah.
hospice. And I spent all kinds of time. I would spend like a week every month there. I think I spent a total of 6 weeks in the hospice with her in the guest room, just kind of hanging out.
Yeah.
And we had the best time. And so he had limited visitations. He ultimately threatened weapons, violence, police. It was a whole rodeo. I'm sure they were happy to see us go at the end. But the bottom line is that Lindsay had her own kind of little like room. It was like supported living environment, but
Yes.
just what she would have needed, honestly, all of her life. If she had had that all of her life, it would have been amazing for her.
Yeah.
And so we were able to create routine, predictability, which is weird in a hospice because people are dying. And I don't know what was going to happen. And her body was changing.
Hmm.
Um, but as much as we could, I was able to set up the environment and the routine so that she actually, you know, actually like enjoyed and explored and found her voice. And we worked on the guide. And I mean, so she did. And then I was there when she died. And we had these family meetings in which she was able to use her voice about what she actually wanted as she proceeded. And because I was able to say, you know, let me back up. I think one of the most amazing things is that when the oncologist was speaking to her, and I was there for all the meetings, she completely understood what was going on. And there were some choices towards the end.
Hmm.
She made them. She made all of them. except for there was one choice the last night. There was one medication that she was unconscious the last night. And it was simply a comfort medication. And I deferred to the nurse. And I'm like, of course, whatever you think, because I don't know any better. But I did have to officially give consent as her power of attorney for medical. And that's it. Other than that, she made her own choices, which was a beautiful thing. I mean, that is a beautiful thing and proof to me that this can and should happen for everyone.
I want to roll back a little bit, and this actually deals with, I'm pretty sure, a previous guest, Kristen Hovert, talks about as well. Who I know,
Paula has been on her podcast.
Yes. Nestor's little family here. So.
Yes.
And talking about the necessity of experienced advocates in this situation. Lindsey, and I've thought this for years, and if I haven't said this to you, I apologize. Lindsey was extraordinarily lucky to have you. Like, her life, especially in the last 5 or 6 years, would have been horrific if it hadn't been for you. And please take that as a compliment, but also give yourself a pat on the back. The difference for you, though, is that you do know a lot about the system, as I would too. I mean, I've been involved in the medical system enough to know some of the things. We are in a vast minority, and so we need professional social workers or advocates to be there in those first conversations or even ongoing conversations. Somebody's experience with cancer. So the doctor's telling the patient, but the advocate also understands medically what's going on within reason and can explain further. But also can stick up and say, do you need this written down? Let me help you. A sister or a husband or a caregiver should not have that responsibility, because you have to be the sister, you have to be the husband, you have to be the caregiver. We do need this professional advocacy. And I was thinking, actually, going back to, even basic things like in education system, if you're getting if you're going through the process of getting Tara, help me out with the term. It's just getting the documentation you get to get special assistance in a school.
Like an IEP?
An IEP, thank you. Thank you. That just went completely out of my head. In all the provinces, there are overseeing boards that can help with the negotiation with the IEPs and whatever. I know they're not used very much, and more parents need to be aware of them. But there is that kind of professional outside body that says, we know this is a complex discussion both ways, and we've got some experience with this. We need the same thing in the health system.
Well, especially when you think, like, of course, although definitely not an easy process, it was probably much easier because you are English speaking, university educated, white, you speak medical language, and not everybody even has a family member or a friend with that type of access. So you might have people going in who don't speak English at all, who don't have anyone with them. You can get a translator, but that's not the same thing as having someone who can say, oh, we should ask this question, we should do that, who can help guide you through the process.
Yeah, we have professional patient navigators in the cancer system, and patient navigation. I don't know if you know, they started primarily with people who were under. It actually started, I believe, in Harlem with Black women experiencing breast cancer, knowing that they had worse outcomes. So looking at what were the barriers to them accessing better care. So there's now patient navigation systems in BC. We have them, well, across Canada. We tend to have them for Indigenous patients, because we know that they have barriers to access, they have worse outcomes, all the things. We tend to have them for rural patients, similar sort of, not sort of barriers, worse outcomes, that sort of thing. And adults, young, AYA, so adolescents, young adults, kids, young people having cancer. And so those are sort of the categories that we have patient navigators for. So we have a system set up saying there are certain populations of cancer patients that we know, for whatever reasons, they're not all the same, will do worse. They're not going to have the same access. They're not going to have the same outcomes. They're going to have extra special problems dealing with the system, such as it is. We've created patient navigation programs for them. So I think we can and should create a neurodivergent
Yes.
patient navigation program. So that's just one of my side project things. However, the problem with that is that you have the what I call the caveats and the sort of takeaways, the cautionary tales. You have the problem of self-identification, and this circles back to what we began talking about, which is the issue of diagnosis. And so you have many people, if you think about people diagnosed with cancer in their 50s, 60s, 70s, 80s, that population right now, what percentage of those people know they're neurodivergent?
Very
Some,
few. Yeah.
some do. No, so we know that we know there are. We're not having a suddenly, burst of new neurodivergent people. We know these people are neurodivergent. But so I have a friend who's a Black woman. She's going through breast cancer. She's like, I'm a Black woman. I knew I was a Black woman going through breast cancer because I knew I was a Black woman before I had breast cancer.
Yes.
So she's experienced racism. She's experienced, barriers to care, all of these things. But that's not new. Her being a Black woman is not new information to her. Right. So she has experienced problems in the cancer care system, but that's not new information for her. So the problem that I have, and I don't know how to fix it, is that if you've got someone who's 50 or 60 and they're late diagnosed, ADHD, they may or may not just be figuring out how their brain and body works, and then they're figuring out how their cancer body works. And oh, wait, they're now figuring out how the cancer care system works, pretty much all at the same time.
Is it worth perhaps, like, I'm just thinking about your guide and all of these questions anyone could answer and say, this is how I process best. This is the environment that makes me feel comfortable. Like maybe we have to move toward this as a universal screener.
Oh, are we bringing up universal design yet again and everything?
I came up to on Friday. We're like, okay, this is how do we identify? No, we're just going to make it neuroaffirming for everybody.
Yeah.
Because we all, and also you look at like dementia, you look at the fact that people's brains and bodies work differently under stress, under illness, under pain.
In menopause and perimenopause for people with ovaries.
Exactly. So can we not be having these discussions about how does your brain work? How do you communicate? What do you need? How do you feel pain? How do you express consent? Who are your people? What's quality of life? Should we not be expanding things like the serious illness conversation guide, like advanced care planning, and make it more inclusive so that we don't have to say, hey, oh, I'm sorry, you've got cancer. And by the way, are you autistic? Because you kind of look a little funny to me.
Yeah, yeah. And you only get this if you have a label, because so many people don't get the labels that they would fit under.
Exactly.
I have been struggling actually quite a lot in the last couple of weeks. And funnily enough, you two are a big influence in this. Is that when I fortunately now temporarily gave up music and went to full-time advocacy, it was like rah, rah, rah. And I am such a strong autistic advocate. I am. I know I've done a lot of great work. But the more work I do, the more this is coming up. The fact that when we're talking about better access to the education system, this shouldn't just be for neurodivergent people. This has to be for everybody. There are kids who need different modalities of delivery systems. They could be neurotypical, they could be neurodivergent, they could be left-handed, right-handed, they could be Chinese, they could be, it doesn't matter. Teachers need the ability to recognize there are different ways of doing something. the health system needs to recognize that most people in front of an oncologist do not understand what's going on. 90% of people don't. It's extremely technically medical what's going on. It's such a different procedure. Everybody needs to be treated that way that they're not going to understand.
Yeah, yeah.
Uh, Nobody signs a legal document without a lawyer. Because legal documents are set out in a way that use very, very specific language and are very, very specific in what they do. The vast, vast, vast majority of population don't understand that naturally. And so you have lawyers. And I'm getting I'm kind of almost shifting my thought process. I've already gone from autistic to neurodivergent because I'm seeing there's no barriers in that. But now I'm thinking this is just maybe I'm a humanist advocate.
Yeah.
And once we start looking at different ways brains work conceptually, the more that should be opening up to everybody going, we need to be
Exactly.
rethinking across the world how things are.
Yeah, there are different ways to communicate, to participate, to process, to, all of these things we can open up to everyone.
And there are some options here because this is where I sort of see it and in the healthcare world too, because the healthcare world is very busy teaching cultural humility, right? We talk a lot about cultural humility in healthcare. We teach it, we take courses, but when I talk about it, I talk about cultural humility, structural humility. So we're looking at the structural barriers, enablers. I look at narrative humility. What are the stories that are barriers and enablers to care? And then I look at neurohumility. So when I'm encouraging healthcare providers, I say, hey, let's have a think about how this person is processing information, right? Let's have a think about that. So we're not just, I mean, I need to, if I'm approaching a patient, if I'm a healthcare provider and they are, they're from a certain cultural background, which means they may or accept or not accept, something I'm offering. They may have a history, may means if I diagnose you with cancer, you're now unmarriageable, that sort of thing. So those sort of things I need to be aware of. Structural barriers. Okay, I can offer you these 10 things to do for your cancer if you don't have a car, a job, a way to get to here, those sorts of things, somebody to escort you, somebody to take care of you at home. Those are kind of structural barriers as well. The financial barriers, the literacy barriers, all of those things. Again, narrative barriers are important as well. And that's where we look at the pre-stories, the backstories, things like medical mistrust, medical trauma and abuse, with many autistic and other neurodivergent people have in the healthcare system that has sort of been set up as healthcare, which means I don't trust doctors because I was sent to so many therapists as a kid. That means doctors, ick, yuck, anything coming out of a doctor mouth, I don't want to hear. That sort of thing we hear a lot. And then that neurohumility, we can cultivate that in our healthcare providers as well, to be curious about how different brains work. So that's sort of, again, that's my little soapbox, that we need to also be teaching that to our healthcare providers as well.
Yeah. And
that like on the side.
No, I agree. And I think, we're getting better generally at having, some places are taking some steps back, but at having things like cultural awareness, like understanding those things, understanding neurodiversity, neurocultures as another aspect of cultural communication. It could be integrated fairly seamlessly to talk about neurodivergent communication at the same time. Yeah.
It really could. So I think with the mistake that I made is I thought the original version of the guide would solve all the problems. No, absolutely not. Absolutely not. So that's just part of it. I mean, that might help a patient, and that would be awesome if it helped a patient and a caregiver, but that's only part of it. It's really
the guide does. The guide does help. I mean, is it going to solve everything? No, of course not. And would have even solved Lindsey? That's an interesting question. It certainly, we have to take pride in that document and know it's
Yeah.
going to help.
Mhm.
But what we're all pointing out here is we have systemic problems throughout all of culture.
Mhm.
And this is again in these areas where I just don't understand. Like, if you, as a grade 3 student, and let me talk about my space here. We live on semi-amu band land, unceded territory. Almost all the schools in our area are very supportive of the First Nations land on which we live on. They all learn about the semi-amu culture, maybe coastal Salish. Great, 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 great. I would hope that that plants a seed in all the kids' minds that I'm being taught about this First Nations land I live upon, but also I have a whole bunch of dark-skinned people, if they're white or vice versa, who also have a different culture, and I'd really like to find out their culture. And that little Johnny over there just always stands in the corner when we're doing playroom, puts his hands over his ears. I wonder why.
Mm-hmm.
That's where my head goes.
Curiosity.
You
Yeah.
you 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 drop one thing about a certain culture thing, and that should spread.
Yes.
How do we encourage that spread? How can we encourage that thought process? Mhm.
Oh,
Is that for me?
was that for you?
No.
I think that's almost rhetorical. It's like, but
Yeah,
I
yeah.
think it's a rhetorical question. Yes. Um, we attack the systems, and we attack the systems from different sides. Like,
Mm-hmm.
we encourage self-awareness for patients, right? So I feel that in my perfect world, um, every patient with every cancer diagnosis would get a copy of a guide that is a kind of a parallel chart, that is a neuro-affirming kind of parallel chart.
Mm-hmm.
And they would have an opportunity, on their own with a support person, however they work, right? To fill that in. And then they would be able to go back to their oncologist or their cardiologist or whoever, a serious illness, and say, okay, so you have the medical information, but you may not know this about me here,
Mm-hmm. I love that.
right? Here's more information. And then the other step is attach that to the medical chart
Yeah.
somehow, attach it to the electronic medical record.
Mm-hmm.
So we need to sort of expand the idea of a medical chart. Please don't shove it all in the social work section. That doesn't help. So that's part of it. Then we need to be training the healthcare providers.
yeah,
Then we'd be needing to be creating and funding, national neurodiversity cancer advocacy programs for the healthcare system, so that if you are neurodiverse and you have a cancer diagnosis or a serious illness, there is a stable of advocates, of Paulas and Bruces and Karas out there who are like, oh, yes, you have a recent diagnosis. Come on in. The water's
Here you
fine.
go. Yeah.
Here you go. So somebody needs to train, fund, create, pay for all of those people. And oh, wait, every province has a different healthcare system. So that's why those advocacy programs, or the navigation programs, are attached to, like, you've got BC Cancers, you've got Alberta Health Services, so we have to reproduce that in every single province, but we could start in one province and then scale up. And then we need to change the physical environments as well, because some of the, Bruce and I have spoken about this, some of the physical environments in the old cancer center where Lindsey was were rooms about, the size of a, tiny little Honda Fit.
Mm-hmm.
And you've got 4 people in there. They're hot. They're crowded. You've been waiting for 3 hours with, fluorescent lights,
Oh,
glaring TVs, flashing screens going on.
beeping.
4 hours thinking, I think I've got cancer. I think I'm about to get really crappy news. Then they squish you in a tiny room with all your people, speed talk the information, or hand you a pamphlet and say your next appointment is bye.
And their head is spinning. Yeah.
My head was spinning, and I'm
I
like,
bet.
I'm taking notes as fast as I can, and it wasn't happening to my. Oh, and then, I mean, there was a day Bruce and I spoke, and then, oh wait, she's off to have a really, painful, invasive procedure where she gets something, in her lungs so she can breathe, so the fluid can come out. So then she has something, quite painful happen to her physical body as well.
Mm-hmm.
And that's in another room. And then we go to another room, and then you're supposed I mean, it's ridiculous. And then off you go, and we'll see you in 6 weeks. And please make a decision about serious surgery in the meantime. Okay.
But
Bye. Yeah.
I remember being in the like when
Yeah.
I had a meeting with oncologists in the basement, the Tom Baker, and at the same time they needed me to do check my heart, which was elevator, and they were doing renovations. Coming out of the building, walking by myself, walking to a completely new building, going through a completely new process, having the EKG done. That's the famous one when the nurse ran out screaming, which is very helpful. And then being told I had to go all the way back to the Tom Baker, down into the basement. And of course, because I had to have an EKG, I missed that original appointment times, had to wait. It was just like, and you talked about medical records. This is one of my pet peeves. I don't know why we can't have aggregated medical records. Every time I go to a new doctor, I honestly have to book an hour to talk about all my medical history because there's a couple of things that are really, really important for my GP to know about. I don't know why I can't have that information just follow me.
Yes. That'd make it a lot easier. That's for sure.
Yeah.
Anyway.
That's a problem for every patient for
Mm.
sure. But I remember, I think the adapting the guide for something specific for healthcare providers came from a situation that Lindsay and I had in, again, Tom Baker. It was after she had her craniotomy, and I was sleeping in this broken down chair beside her bed because I was doing this folding over, I must protect my person vibe. And every nurse that came in on every shift change, and I would say, by the way, my sister's autistic. So for her, this means, and I would list three things. I'm like, I'm going to give you the post-it note version of autism, Lindsay's version of autism. And I'd be like, hey, so my sister's autistic. So like, I would just,
Every time.
every freaking time. And so I remember there was a nurse that came in and she said, I feel like this should be higher up on her medical chart.
Yeah. Yeah.
And I said, bingo, bingo. Because now I appreciate the fact that, she was there. She just had this massive surgery and we had, some medical priorities. But the autism was really important because it was the interpretive framework. It was the experiential interpretive framework for everything that every healthcare provider was trying to offer her in that space.
Yeah. Yeah.
The lens, one might say.
The lens. I don't know. How about the lens? I consider it the basket, but I like the lens exactly. And they weren't looking through that lens.
Mm.
They were not looking through that lens, and to expect the patient to do that. And here's the thing: the structural expectation of self-advocacy is a symptom of a broken system.
Yes.
It is for all of us.
Yes.
So even if you are neurotypical and you walk in, the fact that if I'm not feeling well and I have to go in and go, okay, blah, 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 and I have to advocate for myself all on my
or
own.
you don't get it.
Or I don't get it.
Yeah.
Right. So it's a symptom of a broken system. So I think that's the thing. I created a guide that actually helps the broken system, but I also have to work within a broken system because I can't fix the system entirely.
I've had discussions with ex-clients that in my head they're talking about the same thing, and in my head it's like Roadrunner in the Wile E. Coyote. Sometimes he used to hold signs up. It's almost like you're asleep and you're holding up a sign. She's autistic.
Yes.
She needs this.
Yep. Exactly. Yeah.
Business cards. Sorry.
Yeah. Right.
Yeah.
I wanted to ask a little bit about how Lindsay shaped the guide and how Lindsay felt about the guide.
Well, it's interesting. So the guide emerged from the Lindsay interview project, which is our what started off as just Lindsay and I used to yap on the phone for Sunday mornings. That's our thing. We used to just get in our jammies, have breakfast together, cats walking all over the place, just yip yap for hours. That was just our thing, which I really missed.
I'm
So
sure.
when I realized that she was sick, I'm like, let's record some of these just for fun. Let me just put on my ethnography hat and ask you a bunch of questions about autism and ovarian cancer and just kind of see where the conversation goes.
Mm-hmm.
So I did that sort of through her entire cancer experience was 4.5 years. I did this over the course of 3.5 years. I wish I'd done more, to be honest, but I did what I did. And I remember my husband saying, Lindsay's going to have 2 words to say. And I'm like, yeah, we'll see. She had 2 hours the first time. I'm like, I love this. So the guide came about of me transcribing that and thinking, okay. And then Lindsay and I would do what we call the dream on section, like just dream on, man. Like, but then like, yeah, let's dream on a little bit here. So what would cancer care look like if we could just if we ran the zoo, as we said, if we could just make it up, what would it look like?
Yeah.
So I have these dream on sections. And then I tried to take all of that information and say, well, how can we do this how can we speak about this in a way that isn't 9 hours of interview information?
Yes.
So that's how we came up with the 10 Ps, the person, the patient, the place, that sort of thing. And I would interview Lindsay, then I would sort of compact it and I'd say, what do you think? And then she'd give me her feedback and then I'd give it to her again and I'd say, what do you think? And so that's sort of how that came about. She was very, very proud of the guide. And we won an award from the Inspiring Voices Collaboration Project from the World Ovarian Cancer Coalition for that work together, for the collaborative work together, which is actually, that she also won that posthumously, which is actually really hard because
yes.
I wish that she had been seeing all these things while she was alive. But she knew that the World Ovarian Cancer Coalition was interested in her story and that we were working on that while she was in hospice. And she was incredibly proud of that because she was somebody who, when I've written about this in the narrative medicine world, she's had what I call a clipped, quieted, and too easily summarized and dismissed life and death. And so I want to make it loud, messy, noisy, and memorable. And I want to take it off the charts. I want to take her story off the charts. And so when I think about medical off charting, parallel charting, I want to take that singular story and say, what you knew about her that was recorded in the medical charts is just a small portion of what you needed to know to actually give her better care. So that's true for everybody. I mean, no matter who you have that you've loved and you've lost, that's true for all of us. But I think it's specifically true for people who are sort of deemed to be disabled or different or that. So we actually spoke about the guide on her last night of life, and she I'm going to cry. So she had this sort of couple of hours of resurfacing, which were just a blessing to me. And she really did hope that it would come to its fruition. So, and she did know she was dying. So that was very, very meaningful to me when it came out. Yeah. So that's sort of it's a kind of a full circle or spiral moment. I'm not sure what we call that. So.
And like you, your sister was also awarded the King Charles Coronation Medal posthumously.
Like you.
And like me, I guess. Yeah, like all of us.
That's right.
Which I think is incredible. And I get the sense from your passion that Lindsay fuels you in this work and continuing this work. Is there anything else that fuels your continued passion and perseverance on this topic?
Well, I think of her as a scar and a seed, if that makes sense. So I think of her as sort of my greatest scar and my greatest seed in some ways, because of course I wish I knew more about her autism because I didn't grow up knowing she was autistic. I just had this strange older sister who had behavior issues. And my mother was doing her best and I didn't know what I was doing. So I think part of what I'm doing is I wish I'd done better as a sister earlier. But you did better when you know better. You knew better that you do better. That I can't remember that phrase right now. So part of that is that's what fuels me. And then there's another phrase that fuels me that you could not save her, but you did not fail her. And that comes from Jillian Hort, who's a narrative medicine. She's a physician, but works in the narrative medicine world. And this idea of not saving and not failing and holding those things in tension, which is kind of what grief is about, right? Because of course I couldn't save her. Actually, it wasn't my job. She was going to die.
Yeah.
She was going to die, and she did die. But I did not fail her. So it's like, how could I? So it's sort of exploring, how did I not fail her? And then making sure that maybe if some tiny little bit of some other person's experience in the future is a tiny little bit better.
Yes.
Because of what Lindsey went through and the skills and abilities that I have, then it won't be such a waste that she died at 57. I think is sort of the end of that story, to be honest. That's part of it. The other part of it is that I realize I've always been interested in these sort of medical narratives.
Yes.
That are a little bit different, that are a little bit challenging to the what I call these almost these counter hagiographic medical narratives. That's what links together my original anthropology work, where I did chase medical stories, medical miracle stories around the American Southwest.
Wow.
That was my cool 20s, right? So
I want to hear more about that too.
Well, you're going to need a bottle of wine. But anyway, but the idea of people telling medical stories that are not held by the establishment, that are held uncomfortably by the establishment. And I think as a person right now, looking back, I'm like, I can look back at my career and say these feel like two separate careers, but maybe they were all meant to be together. And maybe my own experience as a patient and as a caregiver multiple times, seeing my people get sick and die. And the other part of the story is my mother died. Lindsay's and my mother died just 3 months before Lindsay's diagnosis. So I had seen my mother through her medically assisted death. And I was playing executor. And then suddenly Lindsay has this cancer diagnosis. So suddenly we're switching from that to this story there. And so it's accompanying my family through what's going on right now, I guess, is part of what's going on as well. And maybe making a change for another family, hopefully.
So that's a lot of caregiving for you over a period. How have you, or how during that period did you manage to like also take care of yourself?
Um, well, sometimes better than others. Let's put it that way. I think it's what I say. It's not my first caregiving rodeo. I made some mistakes caring for my mom when I was caring for myself. But I think that, and for most caregivers, we abandon our own self. That's what happens for most people who are caring for others who are extremely ill, approaching end of life. It's kind of what we do, particularly females. It's kind of our expertise. It's kind of how we roll. I think Lindsay wanted the best for me. Lindsay wanted the best for me. So, I mean, now this is really emotional. On her last night of life, she was worried that I wasn't eating or drinking enough. Right. And meanwhile, like, her kidneys are shutting down.
Yeah.
So the fact that the person who was dying wanted the best for me. And also, I mean, Lindsay and I, part of our joy was makeup tutorials, fashion reviews, and so we had so much silliness and joy and all of those things. And I think I realized that those are mine as well. That you can't just live in the grief and the caregiving world, because you will be destroyed.
Yeah.
And that, so I've done more work on caregiving and grief and end of life care in general. And so practically, I'm very good. I also eat the same breakfast every day.
Yes.
So I'm like, I got to hit those protein goals, those fiber goals, those step counts, those 6 workouts, that yoga. talk to human beings about things other than cancer and death every day. So I make sure that I do those things, get out in nature. I've got to think work for me at the same time. And writing has been a huge outlet. So I've had a few things published in the narrative medicine world that are just story-based, that are storytelling, which also are very restorative for me as well. But that's a specific prescription for me that would not necessarily work for other caregivers.
It's the need of an outlet. It's the need of getting away. I've always cautioned caregivers, and certainly this happened at Autism Canada. It's like one of the first things we said is take care of yourself first. And the metaphor we always used is like when you're in an airplane and the oxygen drops, you put your own first and then the person. And it's logical. If you're not healthy, you can't help somebody. You're gonna fail. I understand there's a whole bunch of emotion that gets involved in that messy little emotional world that we have. Yeah.
But I remember I gave a talk once for Ovarian Cancer Canada about caregiving, and I came up with the metaphor. I don't know if you know the movie Jaws. Do you guys know the movie Jaws? Okay. At some point in time, these like saucy little show-offy guys are like, I know sharks. I know a shark. I've seen sharks. Sharks are my thing. And then they get a look at the size of Jaws and they say, you're going to need a bigger boat. And to me, that's the thing. And so that was the theme. And like, you're going to need a bigger boat. You might think you know caregiving. You might think you've got this all, like, I got my routine. I know what to do. I know how to take care of my person and myself. But guess what? You haven't seen this shark yet. And even if you've been a caregiver for someone before, like having done it for my mom, done it for my sister, I'm doing it for my husband now, they're all different sharks.
Different sharks.
Eat me. Some of these sharks want me. They do want me to survive rather than just eat me, taking them out of the ocean. But there is that threat, that unknown, that sort of circling, that, oh, it's coming up here, it's coming up there. We don't know what's happening. So all of those things, I think, has encouraged me to think about that metaphor of building a bigger boat. And so what do you need? That goes like the physical things, the people, the ideas, the outlets, all of those things. So that's what I would encourage any caregiver, is to consider what kind of bigger boat you need, who goes in it, what goes in it, and that you deserve to still float. You don't want to go down. Like, you deserve, what I say to myself, I deserve to survive this story.
Yes.
So I need to carry the story. I will always carry the story of the people that I've lost, but I also deserve to survive this story. I deserve to be the survivor storyteller. And living with that identity actually has been helpful as well.
It's interesting. You actually could expand that metaphor going back to self-awareness, is that a newly diagnosed autistic person needs to think about building a bigger boat.
I love that metaphor.
Yeah.
Almost, actually, sorry, I was just going to say, it's almost like we can have a new spoons metaphor. It's different, but it's also oblique enough to be quite memorable. And sorry, Cara.
You can get to work on that, Bruce.
Work on that. Just stick that on the side desk. So yeah.
I was just going to say, I obviously don't know Lindsey. I can't really speak for Lindsey, but I imagine, based on what you've shared, that the last part of her life had some incredible sources of richness, and many of them stem from you, though the Zoom calls, the makeup, the getting into hospice care, into a supported environment, and having your presence. So, like, although I know there are the scars there, so I'm getting like emotional, like I think she would really feel that the last part of her life was such a source of beautiful things.
Yeah, thank you. Yeah. Well, we called it her butterfly days.
Oh, I love that.
Yeah, we did. And that's why you see little red butterflies on the guide.
Oh,
That's right.
Yeah, because
Yes.
red was her favorite color. I hate
Nat
red. So,
oh, no, 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 naturally. Red of naturally, naturally.
so she was like, and I mean, the fun thing about this is that Lindsay, because she was on very high doses of steroid dexamethasone, so she gained a lot of weight rapidly. She's like, "This is my body. I'm loving my body. I'm going to dress in bright, loud colors." We had dopamine dressing. We were eating chocolate for breakfast. We were we were doing all the things that she loved, and it was just amazing to see. She tried, meditation through Wellspring. And her sense of humor and lightness came out because of
yes,
the brain tumor. Like she was losing like shoes in the shower kind of thing.
yes.
And we would just be laughing our faces about that.
Hmm.
And I mean, it wasn't all joy. Trust me. I mean, she had pain and seizures, and I think the most difficult thing about that time was, Lindsay was a very optimistic person. And for her to understand, I think that even though she was in hospice, she still thought she was going to be okay for a while. We had to have a final MRI in, I think it was February, that showed over 21 brain tumors.
Wow.
And at that point in time, I think she realized that that was actually the end. But there was part of her, and this was a very fine line for me because I thought, I know that she is in her last months of life, but I also think it is unkind and unloving to be sort of shoving that down her throat constantly.
Yeah, reminding her all the time.
Right. So it forced me as a caregiver to say, how was your day? What's for lunch? What do you think? You know, and I had a new kitten at the time, and I would like put the kitten against the phone and she could hear it purring.
Oh,
So it forced me to live very moment to moment. And I'm a planner and an organizer, which is both a good thing and also kind of not great sometimes. Um, it forced me to actually live in her world,
yes.
which was a beautiful thing. And also now I wish I'd lived in her world more.
Wow.
And I don't know if you know, in some in hospices and in some, actually mostly it's hospices and ICUs, they have the get to know me boards.
Hmm.
I don't know if you know, they're like a patient board, but they're like, my favorite things are my likes, my dislikes, this sort of thing. And honestly, they're part of the dignity therapy, which is part of it. I think they're a great idea. Now, most of these things in the hospice rooms were unfilled out patients or their family members. Like, I don't care. You don't care if my dad likes piano music, or like, who cares? We're not focused on that. Lindsay filled hers out in red ink, um, with her tremor, and I love it because it was like, from the words in red, and it was like all over the place. It was messy, and I that for me was such a grief to have to erase that after she died. So that the healthcare providers had their whiteboard with, like, name of the nurse, da. They had the word autistic written on there. It was never erased, never cleaned. I don't think anybody ever looked at it or cared. Lindsay described her autism in this giant, like, red, messy ink in this get to know me board, which I just love.
Yes.
And to me, that's kind of this idea of this parallel charting as well, but
Yes.
this sort of like visual distinction of it. If only she had had that opportunity to talk back to someone's description of who she is throughout her entire life, in the
Hmm.
school system, in an employment situation, in a relationship situation.
Hmm.
How would her life have been different?
Ooh.
Ooh, that
And
keeps me up at night.
it
Yeah.
it uh, um listeners to the podcast, hopefully when this podcast gets out, what I'm about to say can be make much more sense. But I'm involved in a project which I'm allowed to talk about, which involves filming and talking to very famous persons. And I asked this very famous person whether they were happy.
Mm.
And they said no, for various valid reasons, good reasons for them. And then they asked me, are you happy? And I went, yes, I am, actually. I'm actually really quite happy because I was diagnosed. My diagnosis made me reconsider my life, and I recognize now I am very happy. I was going to say profoundly, but that's probably, there's always ups and downs. I am very happy. I am much more comfortable with who I am, what I am, because of the diagnosis, which is, um, it forced me to have the conversation with me that you've just described that Lindsey had on the board. That's like kind of went, oh, that's a good thing. Cara, what about you?
I would say in terms of the diagnosis, it definitely helped me explain so much about myself and understand myself in a better way, and like let go of things that I was embarrassed about or felt ashamed about, that I just couldn't like wrap my head around why that happened in that situation, why I did that or made that choice. And now I understand what was happening for me. It's like I don't carry those things as these like negatives. So I would agree, like I can approach myself with so much more compassion and give myself things that I didn't realize that I needed. And I think overall my life is yeah, much richer, much happier than it was before, now that I understand myself so much better.
I know people journal for these sort of reasons, but I often have wondered how honest the journaling is. And not to say that somebody is not being honest in what they're saying to themselves, because journals are usually private, but are you deeply critiquing what you're saying? Are you deeply going into what you're journaling about? And recognize that sometimes it just really needs to be, I had a butterfly day today, and I get that. But it's also, a lot of that is, I was forced, Lindsey was forced, unfortunately. Cara, you were forced in a similar sort of way to question. And we had to perhaps think deeper, dig deeper into what those questions actually meant.
Well, almost like we need a guidebook for this.
Oh, wait, now there's a book topic we haven't been talking about for 5 years.
Right.
Paula, how does this tie into that kind of concept of the digging in deeper with your work in narrative studies, medical narratives?
Well, I have a funny story about that. So I did an ovarian cancer sort of narrative medicine, one of my earlier let's write to poetry and prompts things for ovarian cancer Canada. And of course I'm like, Lindsey, you are going to be my guinea pig. I did not give her a choice. And I ran it twice. I ran it once as a pilot and then once a second time. Both times I'm like, you're going to be my guinea pig. So off you go. That was not a question. The first time, and then I leave her with, she didn't really find a lot of expression in writing. That wasn't her vibe anyways, but I said that might be good for her, you never know. And she was already in hospice by then. So the first time she did it, I said, well, can I see what you wrote? She filled it out like she wrote things as if she were performing and reporting for her social worker. And I'm like, that was not the point of the whole. Like, this was supposed to be this like weirdo creative, like, I'm going to give you a poem and this fragment of this thing, and you're just going to do this creative. And I'm like, okay, well, gee, did I fail? Like, what happened? And I thought, okay, just let it be. That's what she wanted to write. So the next time I did it, a month later, she did it again, and then she started to write like feelings. She actually felt something that what her words on paper reflected the things that she had said to me orally. But it's almost like when she started to write, she felt that performative instinct so much that even though she knew, I'm like, this is for you. You can spread it, line your litter box with it, eat it. Like, this is not sport. This is, but that writing for her did not come naturally in a way that's like, this is for my emotions. This is my emotional processing. It did ultimately. Yeah.
But at first she had that awareness of audience and writing for somebody, which is interesting because I thought autistic people can't perspective take. I'm joking, Bruce. Yeah, but it can be such a good conduit.
Yeah.
I've always found for emotions processing, like writing poetry, coming up with images often helps me to figure out emotions. Coming up
Yeah.
with metaphors, and then like it helps me to unpack what I'm feeling as well.
Yeah, so I think if I were to do a writing group specifically for autistic cancer patients, which I've never done,
Yeah.
I would have to think more intentionally about what sort of poetry I'm using. Like I
Yeah.
would use neurodivergent poets for starters.
Yes.
I try to, would reflect that and different images and things so that there would be some sort of hopefully something that's more resonant there. And I would facilitate the group a
Mhm.
little bit differently as well.
I'm going to send you a study I think you'll really like.
Oh,
An
okay.
uh, autistic researcher that I know did a study on menopause experiences of autistic women and had them do artwork and poetry
Okay.
responses,
Yeah.
and it's really
Yeah.
cool. So I'll send that to you
Oh,
because I think you'll
awesome.
like it.
I would love to see that. Yeah, thank you. Um, so that's part of it. I think the second part of it is part of what narrative medicine is foregrounding the stories of the stories we don't hear, right?
Mhm.
So part of it is what I'm doing is when we are telling Lindsay's story or stories of the other Lindsays of the world, saying when you're making decisions about cancer care, like for example, like we need to be hearing all the voices in the same way that we need to be hearing voices of our trans patients and our Indigenous patients
Mhm.
and these other categories that we lump people in, each of which is a huge group, I'm aware. Um, we need to be including these voices in the decision
Yes.
making. Just for example, like when Lindsay went for genetic testing, there was a check yes or no disability box. Check yes or no. Disability, yes or no. I mean,
Mhm.
my head was going, and it wasn't my job to check it. Her oncologist checked yes.
Yes.
I'm like, could we maybe problematize that just a wee bit? And also, why does it matter for genetic testing? I have questions.
Yeah.
You know, so there are yeah, I know. Yes, Bruce, I can see you both growing. Yes.
My puzzled face.
But it's like, is the
Bring it out.
question to do with the way that you are going to be delivered this information, or is this part of the background story for the genetics test, which then you go, each of those is like, are you freaking kidding me? Because that's
Mhm,
such a big box.
It is such
mhm.
a big box. It's like almost like, are you a human being, right? Like almost as big.
Yeah, prove you're not a robot.
Yeah,
Exactly.
yeah.
It's a prove you're not a robot box. Um, I don't know, Bruce. To answer your question, I do not feel it's like how is this information going to be communicated? I think it's um, it's are you male or female? Like how do you identify? Are you black or white? Are you disabled or not disabled? I think
So binary. Yeah.
it's those sorts of questions that are being asked. It's not what am I going to do with this?
Hmm.
Like, do I care if you identify as male or female? How am I going to deliver? Because if you have ovarian cancer and you identify as male, maybe you'd like, not some different information, right? And you have ovaries, you have a risk of, or like God help us, the pink washed world of breast cancer.
Yeah.
So feminized, right? But, males can get breast cancer as
Hmm.
well. So I think that it's probably just for demographics collection, not for actually any helpful
Useful
and
purpose.
useful for the patient. Yeah, no, not at all.
Um, Paula, I'm wondering about your experiences with like anthropological work earlier on. I'd love to hear just a little bit about that, what you did, what it was like studying other cultures in situ, you know?
Other
Sure.
cultures? Other
Other
cultures?
other
Mm.
cultures.
My anthropology was always in my own culture. Mm-hmm.
Mm.
Anyway, sorry.
It's autoethnography, yes. Um, so I originally worked in New Mexico and Arizona with Pueblo Apaches, and back then we called them Navajo, the Dene peoples. And I was interested in the creation of the first Indigenous female saint, Kateri. Back then, so I'm not Catholic and I'm not Indigenous, but I thought this was really an interesting issue to look at how saints are made, how miracle stories are told, cataloged, counted, discounted, and how identities are formed in what we called the postcolonial Catholic Church back then.
Yeah.
Although Kateri Tekakwitha was born in the 17th century, she had at that time and still does a large following across North America, well, actually across the world, but particularly concentrated in the American Southwest. So I just basically chased miracle stories across the deserts of telling miracle stories. And so I did that. And what I heard was that at that time, Kateri was one official miracle short of official sainthood. And all of her devotees, who were of various indigenous varieties, were like, well, actually, the final miracle is the community, is the way that we are gathering and holding conferences and, doing all these things for each other. And we have submitted this to the Vatican. It's the miracle the Vatican won't accept.
Yeah, so I was just thinking that.
Yeah, exactly. I have a paper called that. And so many of these people actually experienced medical miracles, things that they felt were miraculous medically. Many of them experienced things that they felt were like transformational things in their lives. All of these things were then discounted by a system that they still ascribe to. Right. Anyway, so ultimately, Kateri did get her final miracle. It was necrotizing fasciitis, because that's a fantastic medical miracle. It's the flesh-eating disease.
Yes, yes.
Mm-hmm. Yeah, it's very easy. You can count it, measure it. It's like, and then you can stick a relic on it, pray over it, and then everyone's praised. So ultimately, she was granted her medical miracle. But I was interested in basically how saints are made with sort of, quote, underserved populations, and how identity is formed. And how this is attached to narrative is that this is a really long-winded story.
No, I'm fascinated.
Okay, so the only thing we know about Kateri is what was written from the Jesuit relations. Mm-hmm. Okay, which is what the Jesuits wrote, which is basically, please give us more money, kind of letters home to France. We're doing really well here. Dear mom and dad, we're doing really well. Please send money. And in evidence of the fact that we're doing really well, we're converting all of these so-called heathens. The language, of course, was of the, colonial horrendous.
Yes.
So the proof, one of their great success stories, was this young Indigenous girl who they saved from heathendom. And when she died at 24 from smallpox, basically. Mm-hmm. The Jesuits gave her one line in the story. She said, Jesus, Mary, I love you, and died. Well, fast forward many hundreds of years, her contemporary devotees have completely rewritten the narrative. So that's my idea of narrative repatriation. So they're telling her story of how she died back in the 17th century. And they're like, okay, so when she died, she said, my people come together, gather, have conferences. Oh, so I recorded
publish papers.
Oh my gosh. So they're telling these stories, these end of life, and they're ascribing them hundreds of years in the past to justify who they are right now and how they understand this person and their understanding of the miraculous. So that's the idea of these counter narratives, these sort of counter hagiographical narratives, still working within this, overarching system, in this case, the Catholic Church, is the connection to what's going on with me right now. So that's the slightly condensed version.
Wow. I really, I love the idea of collecting stories and making meaning as much as one can. Like, I feel like meaning is always subjective and can be changed from whatever angle you're looking at. Bruce, do you have any thoughts? You look so quizzical.
No, it's not. It's maybe past regrets. My PhD, I tell people my PhD is in orchestration, but it actually is an archaeology document. It's looking at the title of the thesis, not finished, Discursive Formations in Orchestration Treatises 1850-1950. And it was very influenced by Michel Foucault, very, very, very influenced by Michel Foucault's archaeology of knowledge, and the way I started investigating documents. And when you're talking about orchestration, and I'm working in the white Western classical music world, so documents for me was getting away from the standard textbooks and looking at it, and then recognizing things like textbooks are so important for music history, and no one at that stage had looked at that. I'm listening to you going, I was doing the same thing. You're looking at narrative structures. I was spoken narrative structures and reframing stories. That's still what we do in the classical world, in the classical musical world. We are still doing that. And it was the remembrance of coming across Foucault and going, oh, hang on a minute. I need to not just look at the standard histories that everyone has been looking at for the last 150 years at that stage, but things like the letters, things that the eye-opening, and this has got nothing to do with whatever we're talking about. This is a tangent, of course, but the most important orchestration book that most people know about is the Hector Berlioz Treatise on the Orchestration. The English edition that everybody uses a reference was number like 43 in the Gentleman's Library. And document 42 was how to raise orchids. And document 44 was something like bicycle repair.
Yeah.
I can't remember the details, but like that's mind-blowing to me, is that this book that is so specialized in classical music and used only for composers actually was part of a gentleman's library. And then how irrelevant that actually makes it. In other words, it's just a big collection of encyclopedias that really nobody read, or people read passively, but that's the important part of the story. And for you, but the parallel here is that, of course, the Jesuits are going to give a very, very one-sided view, and all the documentation is not actually what happened. We kind of know that historically, but then now you've got these parallel stories, the parallel narratives, which makes the truth this big, beautiful, amorphous blob. Sorry, that's the one thought I had.
I totally see that. Absolutely. Yeah, totally agree.
Amazing. Well, we should probably wrap this up, but it was so lovely to have you here, Paula, and to hear about your work, your ongoing work, to get to know Lindsey through this conversation. I will definitely be posting the Lindsey project and some of the other links that you shared. And yeah, I just really want to thank you for your work, your continued advocacy and development of tools to branch out and help from so many different directions.
Well, thank you for allowing me the opportunity to go off on lots of tangents this
We
morning.
love it.
So, yeah, I feel like I was true to your brand, but thank you,
Thank you.
to talk about this. And I know we'll all be speaking more in the very near future about this project and others. So
Wonderful. So thanks, everybody.
Thank you.
We'll talk again soon.
Bye. Have a good day.
Autistic tidbits and tangents.